Welcome to AETCM, the Emergency Medicine channel. Socialist. Today we are going to discuss the early management of DKA in children adapted from the NICE guidelines 2015. So shall we start?
Yeah.
We come to the DKA in children. Initially, we have to diagnose the disease. As per the history, we will get a history of polyuria, polydipsia, weight loss. The patient present with confusion, abdominal pain and hyperventilation.
May have confusion, abdominal pain and hyperventilation. So polyuria, polydipsia and weight loss. These are the three criteria.
Okay. Then we will check for the criteria is like we will check for the blood glucose that is more than 11 millimole per liter with a pH of less than 7.3 with a serum bicarb of less than 15 millimole per liter. Ketones, serum ketones of beta hydroxybutyrate more than 3 millimole per liter or urine ketones 2+ and above. Usually vomiting, acidotic or drowsy unless more than 5% dehydrated. Then we will classify DKA and the degree of dehydration. We will classify it as mild, moderate and severe. In mild, it is 5% dehydration, moderate 7% dehydration and severe 10% dehydration. In mild, as per the VBG sample, we will get a venous pH of 7.2 to 7.29 and bicarb of less than 50. In moderate,
it's or bicarb of
and
pH 7.2 to 7.29 or bicarb less than 15 millimoles per liter.
In moderate,
either of them is enough. Okay.
In moderate, pH of 7.1 to 7.19 or bicarb of less than 10. And in severe, pH of less than 7.1 or bicarb of less than 5. So based on this, we will classify it as mild, moderate and severe.
Unit is millimoles per liter. That will have to be mentioning. Okay. For MCQs and all, they may try to confuse you with changing this thing. They'll say 5 milligram per deciliter, millimole per liter, micromole per liter. So you should be very specific, millimoles per liter. With the units only you should be mentioning.
So we will divide based on the severity of dehydration and then severity of DKA as mild, moderate and severe. So first we went with the history and the associated symptoms. Then based on the VBG, we have classified it as mild, moderate and severe. So now we come to the management of DKA. First we will maintain the airway, breathing, circulation, disability, ABCD approach. Then only we will go ahead with the intravenous fluids and insulin infusion. We will look at the airway and we will ensure the airway is patent and we will insert a nasogastric tube if there is a decreased conscious level or vomiting in order to decrease the gastric distension. That is airway management. Coming to breathing, we will have to maintain 100% oxygen via face mask with a reservoir bag and we will titrate the oxygen saturation to 94 to 98%. We will avoid intubation unless there is respiratory failure or any respiratory arrest. That is come to breathing. The next is circulation. We will establish an IV access and we will take the venous samples and other routine blood investigations. We will monitor the ECG and identify the shock. And we will also administer fluid bolus and it is also based whether the patient is on shock or not on shock. If the patient is not on shock, then we will give a fluid bolus of 10 ml per kg of balanced isotonic crystalloid or 0.9% sodium chloride over a time of 60 minutes to children. But if the patient is in shock, then we will give the same fluid bolus, that is 10 ml per kg of balanced isotonic crystalloid or 0.9% sodium chloride over 5 to 10 minutes. And we will reassess the patient. And we can repeat up to a maximum of 40 ml per kg if the patient is in shock or the shock persists. Then we come
so basically when such a sick child comes to the ER, you should be ready with your team. As I've already mentioned, you should be ready, you should prepare yourself as well as your team, assign roles, tasks. You take circulation and prepare all the circulation equipments, you prepare all the airway equipments and all, and the other guy prepare the wet flag. Wet flag is weight, energy, tube, fluids, lorazepam, adrenaline, and glucose according to the child's weight. Weight you should be like calculating based on the age. I hope you know the formula of calculating the weight based on the age. Okay, basically from 6 to 12 years, it's basically 3 into age in years plus 7. Okay, and then from 1 to 5 years, it's 2 into age in years plus 8. And if it's from 1 to 12 months, it's 0.5 into age in months plus 4. Okay, if you do not have the Broslow's tape and all these things, quickly you should get based on the child's age. You will get this thing. So basically, these kind of children may come via the ambulance. They'll say that so like 2-year-old child is coming. So basically, you should calculate the weight based on this formula. Prepare the wet flag. Get everything ready. 10 ml per kg is the fluid bolus that we usually give in pediatrics. Okay. So once the child arrives, take him to the cot. Do a manual inline stabilization. Make sure the airway is patent. If something is wrong, you just do the suction. If intubation necessary, you can intubate at that point itself. And then you can move to B, the RR SpO2. Then if RR and SpO2, if it is grossly normal, means B is fine. Then inspection, palpation, percussion, auscultation, the neck as well as the chest. And if that is also fine, means you can be sure about the B. Then move to C. There you will be looking for the heart rate, the blood pressure, the CRT. Based on that, you will get to know whether the patient is in shock or not. Then you place a IV cannula, extract the blood for hematology, biochemistry, blood culture, blood gases, everything, and also the capillary blood glucose. In that, this thing they have mentioned capillary blood glucose, I think so. It's not venous or anything they mentioned for this thing. That can be drawn. And at that point, you get to know, like after assessment of circulation, you get to know whether the patient is in shock or not. If the patient is in shock, you give 10 ml per kg of isotonic crystalloids or this thing, you give it, and you can repeat it to a maximum of 40 ml per kg. If the patient is not in shock also, you are supposed to give 10 ml per kg. But that will be over 1 hour, over 60 minutes. If it is in shock, you are supposed to give it over 5 to 10 minutes. But if it is not in shock also, you give this thing over the fluid over 60 minutes, 1 hour. Okay. In the meantime, you are drawing capillary blood glucose and all these things. So by that, like after some time, you'll get to know the results. Okay.
Then we come to disability.
Sugar also, in the meantime, you should be checking.
Certainly.
Okay.
Then we look at the disability. As cerebral edema is the most common complication in children, we will look for signs of raised ICT like headache, confusion, irritability, posturing, fall in GCS, and rising BP with bradycardia. If it is suspected, then we will treat the patient with 3% sodium chloride or mannitol. At this point of time, if it is present, these symptoms are present, then we will seek a PICU advice and call the anesthetist. Consider CT brain to determine the cause. Then we come to exposure. We will consider sepsis if fever, hypothermia, hypotension, lactic acidosis or refractory acidosis. That is the ABCD management. Then we come to the intravenous therapy, fluids and insulin.
The fever is there, this precipitating cause could be some focus of sepsis somewhere in the child's body. So we'll have to search for that focus also. Okay, and that will be in exposure part. Okay, so then afterwards you again reassess whether the A is okay, B is okay, C is okay, D is okay. Everything is fine. Okay, and like once you give the resuscitation fluid, no? This is the first thing, 10 ml per kg is called the resuscitation fluid. Okay, then once that is given, BP improves. That means your primary survey is over. You have taken care of the ABC. Then only you move to the secondary survey. Okay.
Then we come to the intravenous therapy, that is fluids and then insulin. For children with dehydration, nausea and vomiting, we will calculate the fluid requirement for each child. Our aim is to correct the fluid deficit over the 48 hours. The fluid requirement is calculated as the fluid deficit plus maintenance fluid for 48 hours. The fluid deficit is calculated by the percentage of dehydration into weight in kilogram into ton. And the maintenance fluid for 48 hours is calculated
So
by...
suppose at this point, while you're doing your secondary survey, you took your ampoule history and like secondary survey, you got your the capillary blood glucose level. Okay, and suppose the pH is 7. So what is the degree of dehydration?
Severe.
Severe dehydration. That is the importance of classifying it: mild, moderate, or severe. Okay. So if it is less than if the pH is less than 7.1 or the bicarb is less than 5 millimoles per liter, it's severe. If the pH is between 7.1 to 7.19 or the bicarb is less than 10 millimole per liter, it is moderate. That means 7% dehydration. This is important because unless you know how much percentage of dehydration, you won't be able to calculate the fluid deficit. Okay, because fluid deficit is basically given by the formula percentage of dehydration into weight in kilograms into 10. Okay, that means 10 dW. 10 dW. 10 into percentage of dehydration into weight in kilograms. Just like for this thing, burns and all, you will say 2 to 4 ml per kg into body surface area into weight. So that will be like 4 BW, 2 BW, like that. This is 10 dW. That's an easy way to remember. Okay, so that is the fluid deficit based on the percentage of dehydration. Okay. Okay.
So we will calculate the fluid requirement as fluid deficit plus maintenance fluid for 48 hours. The maintenance fluid for 48 hours is calculated by the equation like 4 ml per kg per hour for first 10 kg of body weight.
That is the 4-to-1 rule. Okay. So first you have given the resuscitation fluid to take care of the shock. Then your plan is to give administer fluid correct the fluid deficit based on the degree of dehydration, and that too, this correction has to be done over 48 hours. In addition to that, you will have to give the maintenance fluid also. This maintenance fluid formula is done by the 4-to-1 rule. Okay, so what is 4-to-1 rule?
It is 4 ml per kg per hour for the first 10 kg of body weight. Then 11 to 20 kg it is 2 ml per hour, 2 ml per kg per hour, and above 20 till 80 kg it is 1 ml per kg per hour for each kg.
Yes.
Then we will correct this over the next 48 hours, and we will subtract 10 ml per kg from fluid requirement for children who did not present with shock.
Yes. That means if it is initially in the primary survey, we told patient if the child is not in shock also, we give 10 ml per kg of fluids over the next 60 minutes. That has to be subtracted from the total requirement. Got it, no? But if shock was there, you need not subtract. But if, in this case, shock wasn't there and you gave 10 ml per kg or 60 minutes. So you subtract this thing from the total fluid deficit plus maintenance. Okay, that is the total requirement. So suppose this is a 4-year-old child came with severe glucose 13 millimole per liter, and the child is bicarb, like pH is suppose 7. Okay, bicarb is 10, and ketones or beta hydroxybutyrate levels are high, more than 3 millimoles per liter. Ketonuria is there, urine ketonuria is there. That is the scenario. And he came with polydipsia, polyuria, and weight loss, and some vomiting also. Okay. So how will you manage this child? The child is in the ambulance. Those guys, like the paramedics, have already given 10 ml per kg of bolus fluid inside the ambulance, and he's reached you. When you evaluated, the child is airway is okay, breathing is okay, circulation wise child is a bit drowsy and she's in shock. So how are you going to go? It's like 4-year-old child.
20 kgs.
So weight will be 2 into age in years plus 8. So 2 into how much? 4. 8 plus 8, 18, 16.
16 kg.
16 kg. Okay. Then, as the patient is still in shock, you should administer again like resuscitation fluid based on the weight. That means 10 ml per kg again repeated. And this can be repeated to a maximum of 40 ml per kg. Okay, one is already given. So another 3 more you can give. And after that, patient got stabilized. What no? Patient got stabilized. C is okay. Then D is okay. E is okay. Everything is fine. And now it's your turn to start the maintenance. You have informed the pediatric, but pediatric PICU on-call is coming late. Okay, so you have started on, your plan is to start on fluids, maintenance fluids. So you calculate the fluid deficit. So what is the fluid deficit here?
Right. At present, patient is in severe DKA.
That means
approximately
10% dehydration. Because 7 pH is 7, bicarb is 10, so severe dehydration. So 10% dehydration. So 10 into
body weight 16 kg into 10.
Body weight is 16 kg into
10.
1600.
Okay, so that is the fluid deficit ml that has to be corrected over 48 hours. Okay, plus maintenance fluid. So this is weight is how much? 16 kg. So 4-1, according to the 4-1 rule, 4 ml per kg for the first 10 kg. Okay, so 40 ml plus
2 ml.
12.
6 into 2. The 2 ml per kg per for the second 10 kg of body weight. That is between 11 to 20 kgs. So how much it will come to?
52.
Total is 52.
Per hour.
Per?
This is per hour.
Yeah.
52 ml per hour.
That has to be corrected?
48 hours.
48 hours. Here you need not subtract that 10 ml per kg because patient was already in shock. The patient wasn't in shock. If I told the patient wasn't in shock, you should have subtracted that 10 ml per kg. Got it? Okay.
Isotonic balanced crystalloids or 0.9% sodium chloride is the initial fluid of choice, and we will add potassium once passing urine. We will also add 5% dextrose to fluid when the glucose is less than 14 millimole per liter. 1 to 2 hours after intravenous fluid commence, we will plan to start insulin infusion at a rate of 0.05 to 0.1 units per kilogram per hour. We will monitor the serum potassium and treat if hypokalemia is present. Usually we do not give intravenous bicarbonate to correct acidosis. Then we will monitor, strict fluid balance should be maintained, and hourly capillary blood gas and blood glucose measurements to be monitored. The capillary blood ketones level 1 to 2 hours should be monitored. Initially 2 hourly, then we will monitor hourly vitals, BP, heart rate, respiratory rate and temperature, and hourly assessment of the level of consciousness, and half-hourly neuro observations including the level of consciousness in children with severe DKA and children less than 2 years old. We will urgently escalate symptoms of headache, bradycardia, changes in level of consciousness, or changes in ECG, ST and T wave changes may indicate hypokalemia.
So basically all these observations should be made in the PICU. Once you, by this time you would have already handed over to the PICU, and there they will be monitoring all these things. That is how it works.